Hello, everyone. My name is Rebecca Henry, and I'm a sophomore nursing major with a psychology minor at Stevenson University in Owings Mills, Maryland. So I completed this research project last semester, and it coincides with Stevenson's biological psychology course under Dr. Angela Setzer. So this course basically provides a biological base of the brain, nervous system, and most importantly, behavior. Genetic and environmental influences are also emphasized, all of which contribute to the development of neurological disorders. So even though neurological disorders such as anxiety and depression are so common, not many people receive the treatment they need. So for example, some may be treatment resistant or may have different chemical imbalances that aren't regulated with common antidepressant methods. And without proper treatment, we are allowing these patients' suffering to persist. So this presentation will basically outline and analyze pre-existing literature and studies about the role NMDA receptors play in depression and provide alternative treatment methods for depressed individuals. So just to provide some background, as a student, I've always been very interested in the link between brain and behavior. And as a nurse, I will be able to apply this knowledge in a practical setting. My ideal career is to become a psychiatric nurse practitioner and to take on more of a leadership role in the field of behavioral health. So this job will allow me to be an advocate for those who are often considered afterthoughts in the eyes of healthcare. So the main objectives of this presentation are to explore common depression treatments, discuss NMDA receptors and their mechanisms, as well as explore the antidepressant effects of NMDA receptor antagonists and propose potential drugs for those who don't respond to common treatment methods. So when we think of depression, we usually think of feelings of persistent sadness, emptiness, and hopelessness. So while this provides a brief snapshot of this disorder, it is more multidimensional than most people think. So the main common symptoms of this disorder usually include the depressed or empty feelings, feelings of irritability, changes in eating and sleeping patterns, apathy, and withdrawing from relationships and activities that were once enjoyable, suicidal thoughts or actions, and as a result, day-to-day tasks become more difficult. So this disorder can result from certain genetic predispositions, traumatic life events, or simply from chemical imbalances within the brain. So depression can take many forms, as we see from the many types listed on the slide, and these symptoms can be portrayed in different ways. So these chemical imbalances in depressed patients typically involve neurotransmitters. Neurotransmitters are chemicals used to communicate within our body, so between different parts of the nervous system, organs, and other organ systems. So if we don't have sufficient levels of certain neurotransmitters, these chemical imbalances can cause some malfunctions to occur within the body. This is also where medications come in, as many of them aim to regulate these neurotransmitter levels. So many cases of depression can be linked to reduced serotonin levels within the brain. Serotonin deals with mood, and a deficit in this chemical can cause these depressed or empty feelings. So dopamine is also involved in depression treatment. It deals with pleasure and rewards within the brain. Glutamate's another important one, the main one we're going to be focusing on in this presentation. It's used in learning and memory. It's also the main excitatory neurotransmitter in the body. So basically stimulates the body to complete tasks or do things. And then we also have noradrenaline, also called norepinephrine, focuses on concentration and can also be released in stressful situations. So for example, fight or flight. So these are just some common examples of antidepressant drug categories, as well as some popular examples listed underneath of them. So you might be familiar with some of these drugs through commercials or advertisements. So we have TCAs, which are tricyclic antidepressants. They block the reuptake of neurotransmitters such as serotonin and norepinephrine. And some common examples are nortriptyline and amitriptyline. We also have MAOIs, or monoamine oxidase inhibitors. They block MAOs, which break down serotonin, dopamine, and norepinephrine. And then we also have SSRIs and SNRIs. SSRIs limit the reuptake of serotonin, and SNRIs limit the reuptake of serotonin and norepinephrine. So some common examples include Celexa, Lexapro, Prozac, Zoloft, and Cymbalta. Wellbutrin is also a common antidepressant, but uses a different mechanism that blocks dopamine. So what happens when depression patients don't respond to treatment or are treatment resistant? So considering depression is the third leading disability in the world, you would think we would have explored all possible treatment options. Still, however, 1 in 3 depressed individuals are treatment resistant and struggle to find the treatment that they need. So a likely explanation could be that different neurotransmitters or mechanisms are involved in some patients. So recent studies have revealed glutamate imbalances in patients with major depressive disorder, specifically in their prefrontal cortex. So the prefrontal cortex is an area in the front of the brain that deals with decision-making, planning, and personality development. It receives a lot of attention because it is one of the last brain areas to develop and not be fully developed until about age 25 to 30. So this brain scan listed below points out where the prefrontal cortex is located. So the first image we see a superior view or a view from above. And then in the second image, we see a sagittal view or a view from the side. So the brain regions that are especially in question here are the dorsolateral prefrontal cortex, which is towards the front of the body and on the side of the brain, and the medial prefrontal cortex, which is towards the center of the brain. So these will be discussed in the next study. So this table is based on a 2018 study done by researchers within Keio University's Department of Neuropsychiatry in Tokyo, Japan. So compared to non-depressed individuals, those with depression reported lower glutamate levels within parts of their prefrontal cortex. So these lower glutamate levels are indicated by the negative values within the table we see on the right. So GLX is a combination of glutamate and another chemical called glutamine, which is an amino acid. So GLX may be referred differently in some literature, but in this case, that is what GLX means for this article. So based on the study, researchers concluded that alterations in glutamate levels play a significant role in depression patients, and the common drug types like SSRIs, SNRIs, TCAs, and MAOIs don't specifically deal with glutamate, so a different receptor type may need to be explored in patients with these specific chemical imbalances. So this is where NMDA receptors come in. So these receptors are called N-methyl-D-aspartate receptors, or NMDAR. They deal with glutamate. So drugs involving these receptors are often prescribed to Alzheimer's patients as they target memory deficiencies. So NMDA receptor functioning can also decline with age, which may result in some of these memory issues. Pyramidal neurons are one of the main neuron types found in the brain, and NMDA receptors can affect this pyramidal neuron firing in the hippocampus, a brain area that deals with memory. So NMDA receptors follow an ionotropic mechanism, which means they almost act as a gate. So when the correct ligands or chemicals bind to the receptor, this will cause the receptor to open, and certain chemicals such as calcium can then flow through the channel. So the mechanism of these receptors, they follow a graded response. So basically this means that the intensity of the response depends on the intensity of the stimulus that is activating the receptor. So when glutamate and glycine bind to this receptor, this allows the two subunits to then separate and allows calcium to then exit the cell. So it's a very sensitive and specific mechanism. It's not a guarantee that the calcium channel will open even when sufficient glutamate and glycine ligands bind to the receptor. So NMDA receptors can easily be overstimulated by everyday stressors, not just in those with depression. So when these receptors are overstimulated, glutamate levels then increase outside of the cell. And this excessive glutamatergic signaling can induce excessive calcium levels, which is actually very dangerous and can kill neurons, which don't regenerate in the nervous system besides certain brain areas. So just some additional features about these receptors. They're important in cellular homeostasis, so maintaining equilibrium and balance within the body by regulating calcium flow. They deal with synaptic plasticity and strength. So you want your synapses to be as strong as possible. This is basically your neurons communicating. This is especially important in learning and memory. Your body must be able to communicate in all conditions, obviously, and luckily our NMDA receptors aid this process. So without strong synapses and the ability to adjust in certain conditions, some important signals may not be sent, which can cause malfunctioning to occur within the body. So this also deals with long-term potentiation, or LTP. This causes the repeated stimulation within the nervous system, which significantly increases messages sent between two neurons. Neuroplasticity is also an important feature of these receptor type. They affect the brain's ability to adapt to certain conditions. So with all this being said, it's obvious to see that NMDA receptors play a very important role within the brain, but when overstimulated can contribute to serious issues within the nervous system. So this covers how an NMDA receptor is activated. So when two molecules of glycine, which is an amino acid, bind, followed by two glutamate molecules, which is again a neurotransmitter, magnesium will then be removed and allowing the channel to open and calcium to flow through. So this leads into the glutamate hypothesis, which heavily involves these NMDA receptors. So it basically states that reduced activity at glutamate synapses, such as those at NMDA receptors, can be linked to neurological disorders such as depression. So by blocking the excessive stimulation of NMDA receptors, NMDA receptor antagonists have exhibited antidepressant properties. So antagonist drugs prevent the correct ligands or neurotransmitters from binding to that particular receptor. So if a receptor is being overstimulated, antagonist drugs can then be prescribed to regulate this receptor functioning. So memantine or Namenda is an NMDA receptor antagonist drug often prescribed to Alzheimer's patients. So in this diagram, even though glycine and glutamate are binding to the receptor, memantine is preventing any calcium from leaving the cell and acting as an antagonist. So another feature of this is when used in combination with opioids, NMDAR antagonist drugs can exhibit chronic pain relief in addition to their antidepressant effects. So these antagonist drugs are very important in regulating glutamate levels within the brain and preventing excess amounts of this neurotransmitter and calcium, which can actually damage neurons within the body. So clinical research shows promise in alleviating depressive symptoms in mice and humans. So NMDAR antagonists were first used in the 1990s by researchers Ramon Trellis and Phil Skolnick in an experiment called the mouse force swim test. So this is basically used to evaluate the effects of antidepressant drugs. So mice are placed in a glass cylindrical tank filled with water, and their efforts to climb out or escape the tank are then measured. So if we see an increased mobility, this means the drug exhibits antidepressant effects. If we see a decreased mobility, this means the drug does not exhibit antidepressant effects. So according to a study in 2010 by researchers at the University of Tehran in Iran, NMDAR antagonists significantly increased mobility time of the mouse in the mouse force swim test, which means that antidepressant effects were exhibited. So there's been limited clinical research on the use of NMDAR antagonists available due to the ethical issues associated with ketamine, which will be discussed later on, but these drugs have shown promise in rapidly relieving depressed symptoms in treatment-resistant patients. So this is just a visual representation of the mouse force swim test, which is, again, a common experiment for determining the antidepressant effects of drugs. So mice are basically placed in these cylindrical tanks, and the effectiveness of the drug is revealed in the mouse's effort to escape. So if we see any climbing, that means the drug exhibits antidepressant effects, and then if we see immobility, it means the drug does not exhibit antidepressant effects. So this table is based on the results of a 2013 study examining the antidepressant effects of ketamine, as this drug is one of the common NMDAR antagonists used in depression studies. So the Montgomery-Åsberg Depression Rating Scale is a questionnaire used to determine the severity of one's depression. So this is one of the most common scales used to evaluate depressive symptoms in clinical research. Categories such as sadness, changes in sleeping or eating patterns, lack of emotion, and negative or suicidal thoughts are all rated on a scale of 0 to 6. So the higher the score, the more severe the patient's depression is. The highest score is 60, and here we have a mean score of 14, which indicates mild depression, which is a score calculated after administering the ketamine to the patients. So within just 24 hours of administering ketamine, more than 64% of them experience a decrease in their MADRS score. So then we have the quick inventory of depressive symptomatology, and it basically includes 3 domains that are assessed. So this includes sleep, appetite, weight, and then restlessness and agitation. So the total score of the inventory ranges from 0 to 27. Again, the higher the score, the higher the severity of the depression in the patient. And here we see a mean score of 8.38, which indicates, again, mild depression. So we're seeing a decrease in these symptoms. The Clinical Global Depression Scale measures improvement of depressive symptoms in patients after 24 hours of administering an NMDAR antagonist drug. So about 62% of participants experienced significant improvement in depressive symptoms within just a day of administering ketamine. And over half the participants had significantly less severe symptoms compared to before administering. So as shown in the study, ketamine targets these NMDA receptors and is used to maintain balance and homeostasis within the body, therefore creating a sounder mental state. So besides depressed patients, ketamine can also be administered to schizophrenic patients to regulate their glutamate imbalances. So this is a table based on clinical research conducted in 2021 by researchers of the Medical University of Silesia in Poland. Memantine is also an NMDAR antagonist drug that has shown promise in alleviating depressive symptoms. Even low dosages of 20 milligram memantine exhibited antidepressant effects in patients with bipolar depression and show significant impact in stabilizing the moods of these participants. So memantine can be paired with other drugs, unlike ketamine, and are unlikely to display adverse side effects. So even though memantine has a less rapid effect than ketamine, low dosages over the course of 7 weeks produced a 35% decrease in the HDRS-17 score. And this is just the Hamilton Depression Rating Scale used to evaluate clinically significant response to drugs in individuals with depression. So this graph shows an overall downward trend in these scores after administering memantine compared to their initial scores before treatment. So while ketamine produces rapid antidepressant effects in both mice and humans, it is considered unethical. So it is used as an animal tranquilizer and exhibits hallucinogenic effects. It's not FDA approved. It can have significant side effects such as memory loss, increased neuronal death, and it can easily be abused because of its rapid effects. So memantine, on the other hand, is approved by the FDA and is a safer option than ketamine. So although its effects aren't as rapid, it has all the same benefits that ketamine exhibits in depression patients, with a low probability of psychotic effects. It can be used with other drugs, it's unlikely to be abused, and it does not induce cell death. So with this, memantine shows promise in safely alleviating these depressive symptoms in those who fail to respond to common treatment methods. So this research is only the tip of the iceberg. NMDA receptor activity affects more than we think, not just in those with depression. So overstimulation, again, in NMDA receptors can be caused by everyday stressors. So NMDA antagonist drugs can help regulate this receptor activity and reduce increased glutamatergic transmission within the nervous system, which ultimately avoids serious issues within the body, such as neuronal cell death and weakened synapses. So the ultimate goal of this research is to find and explore alternative medications for those who do not respond to other common antidepressants or are considered treatment resistant. So the goal is to direct more attention on these mental health patients and identify specific chemical imbalances within these patients, preventing just blindly prescribing drugs. So the longer we sit on this research, the longer these feelings of helplessness and sadness will persist in treatment-resistant depression patients. Exploring a different type of receptor and mechanism other than those involved in typical antidepressant drugs may offer alternative treatment methods for those suffering from depression, ultimately allowing more individuals to finally be able to reconcile with their illness. So this concludes my presentation on the role of NMDA receptors in depression, and I want to thank everyone for listening. I also want to thank Dr. Angela Setzer and Dr. Rivka Glazer for guiding me through this process and supporting me through all my research endeavors. Thank you everyone for your support and enjoy the rest of the conference.